Okay, welcome everyone and good morning to this is session 3 of our RaCEEs course, and today we're going to cover costs. Like last time, I'm running this session with Luís. As usual, I have to remind you that this session will be recorded and will be made available on the ARC No West Coast YouTube channel. There might be some delays this time because the comms team is a bit busy with the ARC2 application preparation, but I'll try to share at least the file with you on Teams as soon as I can. If you have any questions about the recording, please let us know. Okay. So before we actually start with session 3, I just want to ask you if you had any problems with the homework post session 2. I know many of you have managed to complete the homework. Probably some of you got some questions. If you got any burning question now, we can go through some of the issues. Or if you want to ask your team leads later on, of course, they're more than available and more than happy to help you. But if you got any quick questions now, feel free to unmute yourself and ask us. Okay, let me check the chat as well. Okay, I'll just move on for now. But if you have any question even later on, just let us know, please. Okay. So this is session 3. We're going to cover costs. We are still within the methods of an economic evaluation. And this is, again, a slide depicting the structure of our commentary. So we are still within the method section of our commentary, and we're going to try to talk about cost data this time, how to extract cost data. And then we provide you some example of how we summarize cost data in the past. So the aim for today's session, as I was mentioning, is to identify and describe the characteristics of the cost data used in an economic evaluation. We'll talk about total costs, resource use, and unit cost, which are the main cost concepts which we need to learn about today. And then we will cover very quickly currency and price here as well. And Luís and I will have some slides dedicated to total cost, resource use, and unit cost, and with some examples which will help clarifying all these concepts. Okay, this is the diagram which I'm going to propose in every session. It's typical economic evaluation with a choice between two alternatives. You could have more than two alternatives, of course, but we try to do a simplified example here. And today we're going to cover on the cost side. So we're looking just at the cost of the two alternatives and how to measure this cost, how to value these costs. So the first concept I want to talk about today is total cost. As you can probably guess, total cost is something that we will measure in monetary units, and it represents the total amount of cost specific to a category of cost, or maybe to a number of categories of cost, and we will have some examples in a minute. What we need to remember for now is usually on paper, total cost is measured by considering resource use, which is something that we measure in natural units, and Luís will provide some examples later about resource use, and unit costs. So the multiplication between resource use and unit costs will give you total costs. So if we have, for example, 10 minutes with our GP, that will be our resource use. We multiply that by the unit cost of 10 minutes of GP's time, and then we will get the total cost for the specific service, in that case, consulting a GP. And the same for any other type of health or social care resources, for example, medications, treatments, surgery, and so on. It's always a combination of understanding how much we use a certain resource in terms of time, number of tablets, number of equipment, and so on, and how much it costs in its unit form. So how much one tablet of a certain medication costs, how much 10 minutes with my GP cost, and so on and so on. We got different types of costs, and I'm sure you are very familiar with the type of costs in health or social care intervention, but this is just a recap of what we consider in terms of categorization of cost in an economic evaluation. First of all, as a minimum, we will need to consider direct medical costs, which are strictly linked to the provision of healthcare. Some examples are here, like generic care, medications, consultation, treatment and procedure, test and rehabilitation. And for each of these, we will need to consider resource use and unit cost in the same way I was mentioning a few seconds ago. Then if we want to capture something more, we will need to capture something like direct non-medical costs, which are broadly linked to the provision of healthcare, things like travel, accommodation, food, home modification, and other items. So these are not really strictly linked to the provision of healthcare, but they're broadly linked to the provision of healthcare. And among some of these, there might be some patient's cost, of course, if you think about travel, for example, or possible accommodation and so on. Again, if we want to expand what we're trying to capture, then we will cover as well indirect costs. And this is to do with things which are outside the health or social care realm, in a way, things like lost income for patients, but also for families and caregivers which need to assist the patients. Lost work days, so we got some impact on employment, again, for patients, for families, for caregivers, which might trigger some productivity losses on the part of the companies employing patients or the families and the caregivers. And the more we expand the types of costs we capture, the more we expand our perspective. Now, perspective is a concept which we covered last time, if you remember, and represent the types of costs and outcomes that we want to capture in an economic evaluation. As a minimum, we will need to capture direct medical costs, which are linked to the health system. This is the minimum that NICE prescribes us in terms of capturing in an economic evaluation. Typically, you will also need to try to capture some direct non-medical costs, which could be, as I said before, related to patients, out-of-pocket payments, and so on. And if we really want to embrace a larger perspective, then we can try and capture indirect costs. But these are kind of, we call them externalities in economics, some external effects that the intervention might have in other industries. For example, we talk about companies might incur productivity loss. Think about, for example, education system for interventions on children. So there might be other industries which are affected by specific health or social care interventions, and we might want to capture these indirect costs on these industries. But the more we span the perspective, the more it's getting difficult to capture everything out there, because some of these things might be intangible, so there might not be a very quick way to measure them, and that could be quite challenging. Any questions so far? Okay, Luis. I think you're on mute, Luis.
Sorry, are you still sharing? Just for me to share my screen.
I can share this slide, and then I'll got another slide later, and then you can start sharing.
Okay.
That's fine.
Okay, so like Valerio explained, you have to compute the resource use, and then you have to compute the unit costs. So let's start with the resource use. I think in a way Valerio already explained what it is. So these are the units, the natural units that you have in terms of the service. So if you read this, it says resource use refers to the use of healthcare staff time, facilities, and consumables, especially medicines. So for instance, if you are accounting for an admission of a patient to the hospital, it is going to be the resource use that refers to the use of healthcare staff time, facilities, and consumables for that given admission of that given patient. Now, I think Valerio also explained this very, very well, so I won't spend too much time here, which is the costs that you are going to consider, the resource use that you are going to consider to then compute the costs is going to depend on the perspective that you choose. And here I have three potential perspectives. For example, we have the payer side. If for some reason you are doing an evaluation where the most interested agent is the payer, then you need to understand what are the type of costs, the resource use, and then later on the unit costs that are relevant to that payer. Let's say that we are doing an economic evaluation on the patient perspective. What does the patient care about? So the patient goes to the hospital, let's say is sick, needs to be admitted, is admitted, goes home. What does the patient care about? Well, if the patient needs to pay for that admission, the patient cares about the cost, the payment, the price of that admission. So the resource use that you should consider is anything that is going to play a role into costing or pricing that admission. Okay. Just a note that I'm considering that the patient is going to pay. I know it's not the case here in the UK, in the NHS, but there are some countries around the world where that could be totally possible, or even here in the UK if you go to private service, for instance. Now, the payer may be an insurer. Let's say we are something like the USA, and then a type of more leaning towards to the insurance scheme, and then the patient goes there, the patient is admitted, receives all the care, and then the insurer needs to go and pay. Again, it's the payer cares about what are the type of resource that is used in order to produce that admission, and that I will have to pay for. Now, alternatively, you may have the healthcare perspective. So the healthcare perspective, in a way, is going to, of course, have all these things that the payer's perspective has, but it can be a little bit broader because it can, for instance, include administration costs. So there are resources. Let's say here you have the NHS, and the costs of an admission may not only be that admission and all the materials and all the staff and so on that is required to do that admission. You also have administration costs of the system that may be eventually inputted, may be used to spread around all the services that the National Health Service is providing. So it may be slightly broader. For example, even if you have some out-of-pocket payment, which again is not the case here in the UK, but at some point in Portugal there was some experimentation where, of course, the state would pay most of it, but then the patient had to pay a little bit. That payment from the patient should still be included in the healthcare perspective, because it is part of the costs for the entire service, for the entire healthcare, and it should be accounted for, because the idea of the National Health Service is to serve the patient. Now, finally, as Valerio explained, you can go broader and broader and broader and achieve the society perspective. So if you want the society perspective, this is where you are going to start including a lot of indirect costs. So you are going to start including, like Valerio said, the time that someone loses to do other things, if that person is sick, or if that person is admitted or something like that, the productivity. You are going to have all those things into account into the economic evaluation. Please, Valerio. Now, again, a little bit of a repetition because we have been talking about that, but commonly recorded items of resource use can be GP or specialist visits, can be hospital admissions, like the example I was providing. It can be hospital bed days. It can be medications administered, and some others. Now, just a very minor note that when you are doing, for instance, this course and you are looking at economic evaluations, they will most of the times rely on information coming from clinical trials. Just to say that you need to be careful, and this is going to be part of your critical appraisal and the implementation for practice speeds of the commentary, to understand if the information in those coming from those clinical trials can be generalized to a situation where that type of care is being provided across, let's say, the entire country, for example, when it is scaled up. So here we have that this note saying that resource use data collected in clinical trials may be of limited value for economic evaluations because of the inclusion of protocol-related elements like study visits, care in specialist centers, which may not be representative of routine care. So make this exercise when you are doing the commentary, which is to understand if things that are in the economic evaluations that you are looking at, if they are generalizable or not, if it is going to be hard to implement all of that in the same way when you try to scale it up to the entire system or not. So before going to the next slide, which is going to be Valerio's, I want to practice a little bit with you. Now, imagine the following. Imagine that we have, you are injured, you have a knee injury, and you need surgery. And you go to the hospital to receive a surgery to your knee, so you will be able to get better. I just want you to participate a little bit and try to list potential resource uses. You can go to find measures, just list things that you should consider in order to try to compute the costs. So we don't want the money right now. It's just what do you need in terms of the service for any injury? What are, in terms of staff, in terms of material, etc., what do you need to account for in the costs? So now I would be happy that you participate. So anyone?
I'll say some things.
Sure.
Like X-rays, anaesthetist time.
Sorry? Yes.
If you need an operation, thinking about anaesthetist time, equipment for an operation, surgeon time, other staff involved, bed stay if you need to stay in hospital. Any kind of like crutches or braces or consumables relating to a knee injury.
I think you almost said all of them, but is there still anything left? Anyone that reminds any other? But that was very comprehensive. Thank you.
Would there be sort of, would you count in things like time off work or things like rehabilitation, post-op sort of physiotherapy and things like all that kind of thing as well? So not just the procedure, but the after the procedure, the costs as well. Would that be, you'd have to consider?
Oh, good question. I'm just wondering because and Valerio, please step in and correct me if I'm wrong, but I would assume that it is going to depend on the perspective and who's paying for what. So I would assume that if the healthcare system, so let's say the NHS here is paying for everything, then yes, you are going to account for everything. You are going to account for the surgery and then the rehabilitation. So yeah, but imagine that. I think so. If it is like the insurer pays for the surgery, but then doesn't pay you for the rehabilitation, which probably it does, but then you'd probably only count the things related to the procedure. But what do you think, Valerio?
You're right. It depends on the perspective, but like for example, if you have a way to measure like lost work days and things like that, and we'll come to that in a minute. Actually, how we can capture all this type of information. That would be really important because it will help you understand whether maybe the intervention is saving some work days, and that you need to account for them, and it will look more cost effective if you try to account for these things, of course. But Luis, yeah, you're making a good point. It depends who pays for these things, like for example, rehabilitation, surgery, and all that. So it's good to differentiate about the actual payer. And then if you can capture, yeah, that's fine. But it's also good to differentiate between the payers, because at the end of the day, when we prepare an economic evaluation, we prepare it for a decision maker, and they need to make the decision based on their costs. And the outcomes of specific interventions. So they need to be able to decide according to specific costs and outcomes. Yeah.
But if we want to simplify and say societal perspective, where everything counts, basically, then yes, of course, you need to count the procedure, you need to count the rehabilitation. Like Valerio said, imagine that before the procedure, you were losing working days because your knee wouldn't allow you to work as much. Now you also need to count later. This is weird. I shouldn't have gone there. But well, you need to count those costs that you now don't have. So it's like a benefit in the sense that you stop having some costs of missing work. So yeah, then you can count several things.
Okay. Shall I go
Because you could,
yeah. Sorry.
Because you could argue around, if you're having recurrent time off work versus one solid thing of time off after a procedure and then you're back to work fully. Do you see what I mean? So
yeah.
What do you factor into a cost evaluation?
No, that's a good question. I mean, of course, you should be able to look at things for a good period of time in order to see people are reinstated into work, and the time horizon is really key there. Being able to understand, it's not only a 3-month study period, but we need to probably look at 6 months, 1 year. If they go back to work and they stay at work as well, if they don't have any other problems, which might be related to the intervention. And that's where I think it becomes challenging, because you can only follow people for a certain period of time, or that's what we do in economic evaluation. In order to model to the lifetime, we use modeling techniques, which Luís was describing in the last session. So there's always a bit of, let's call it guesswork, but it's not really guess. It's like an educated guess, let's say, that we have to do to model the long-term pathway of a patient. Yeah. Any other questions or points?
Can I just mention, sometimes we have the morbidities like in prematurity, they do need to come for a lot of appointments for eye clinic or for a follow-up, neurodevelopmental follow-up, or something that we intervene or we give the intervention that reduces that sort of appointment. We should also take that into consideration, isn't it? Now with the new cost of living, people coming for that appointments from all over Northwest for one specific tertiary hospital, it could be very costly for them, whether they travel charges or a breakfast, lunch for 2 of them, and those sort of indirect costs should be considered as well, isn't it?
Exactly, absolutely. I mean, Andy and I did some research in, for example, stroke care in India, and out-of-pocket payments were, let's say, a very, very big proportion of total cost there. And if you ignore them, like you ignore a very, very good portion of the impact of an intervention. So whenever you think out-of-pocket payments are going to be very impactful and meaningful, you need to capture them. And that's where the connection between economists, clinicians, patients representatives is really key. So we're not working in our tower, we're working with other people in order to understand the trajectories of patients and the impact on patients as well. Really good points here. Thank you everyone for making these points. Yeah. Any other questions?
Just a quick question from me. Yeah. And I'm thinking about this in terms of the time horizon. So using the example is used as well. Somebody had an accident, for example, a knee injury, and let's assume that, okay, NHS is paying, not like insurance, whatever. So how do we consider the time? Because when you talk about rehabilitation, for example, there are some post-surgery rehabilitation that are necessary, and some might require maybe they are all necessary to get your feet back. But at some point, the person might be able to go back into some partial form of work. But how do you determine the time horizon? Is it in terms of, okay, when the leg is finally healed, or we need to... So those kind of things, because that will also influence how we account for some of these indirect costs or benefits.
Absolutely, yeah. That's why the time horizon is important to set that up really straight at the beginning, and that comes is a decision comes as a consultation, like I said before, with clinical experts and patient representatives to understand how long you need to evaluate a certain intervention, and you also need to consider whether you got data available to be able to model for a longer period of time. If the data is not available in your study, going to look at the literature, scoping the literature, maybe other studies did have a longer follow-up. In certain cases, it's possible then to, combine studies from the literature with your own modeling and try to then evaluate an intervention in the long term. But these are all decisions you need to make straight at the beginning. And like, for example, we got trials at the moment where the data is being collected, but we already made some scoping work of the literature to kind of fill in all the data gaps, because the trial will only be for 6 months, 1 year, but we need to be able to extrapolate the data into the long term, might be the lifetime of patients in some cases, yeah. Thank you everyone for all these questions. Really good to see so much interest around these issues, because I think costs are always seen in a negative perception, but we need costs. We need cost in order to invest in resources, invest in equipment, and so on. And so they are necessary in economic evaluations, fortunately or unfortunately. I just want to cover this slide, which I think is a bit tangent to what we're covering today, but it's just to give you a sense of how we collect data on resource use in economic evaluations. It's often good to collect first-hand data, so directly from the patient, in the form of case report forms, patient questionnaires, or diaries. Now, some of you might have been involved in trials or studies where they had to be consulted in the design of, for example, patient questionnaires, or some of you will need to be involved in the future. So it's good to have an idea of how things work. And in this case, for patient questionnaires in particular, for diaries as well, there's often a conversation between economists, clinical experts, on how to best design these instruments. For example, for patient questionnaires, we work a lot with, for example, the stroke research team here at UCLan, and we need to consider how much people can remember. If we apply a questionnaire 6 months into the study, and we are going to ask them how many appointments they had with the GP in the last 6 months, how many treatments they had in the community service in the last 6 months, and so on. You often deal with people with cognitive issues, and they might not be able to remember all these things for the last 6 months. And then you think, well, maybe a solution is to do like a questionnaire every month, but then that will increase the burden on the patient. So there is a trade-off between frequency and recall there, which we need to consider. The same for diaries. If you ask people prospectively to record the type of appointments, the number of appointments they had they will have in the next 1, 2, 3 months, it might be challenging for some categories of patients. That's why it's always good to try to validate or complement first-hand data with other tools out there, like electronic health records, literature. As I was making an example before, there might be other studies with good data available, for example, core studies, which could help us understanding a bit more the costing paths of certain interventions. Data sets will be available as well, or public sources like guidelines. Sometimes they provide you, or they should provide you with examples of how many treatments a patient needs to have in case of let's say, stroke, cancer, and so on. So what kind of tablets they need, what kind of medication they need to take, and so on. So according to all this information, you can try to then cost all these resources. So this is just a slide to help you understand with an healthcare or social care resource use questionnaire, we can capture all these resource use which patients will have in a certain period of time, including potentially lost work days. So you could ask the impact on employment as well, if anybody had to have time off as a consequence of receiving a specific intervention. But that's where the conversation between economists and clinical experts and For example, the clinical trials unit is very important, because if it was left to us economists, we probably do like a 30-page questionnaire, and we will ask loads, but we can't, because there are other questionnaires which the study team will need to apply and ask the people. So we need to be careful on how much we can ask. Any questions? Okay, I think I'll stop sharing, Luis, and then you can take over.
Okay. Just in the meanwhile, while I'll share, just a note that always the economic problem, even to do questionnaires, so many needs, so little resources, right? So, okay, so Valerio started by telling you that in order to compute the total costs, you need the resource use in monetary units, in natural units, and then you need the unit costs in monetary units. So we already talked a little bit about resource use. Let's now talk about the unit costs. And a unit cost is the total expenditure incurred by a company to produce, store, and sell 1 unit of a particular product or service. You will note that we have here incurred by a company, because it doesn't need to be only for healthcare. This is, in fact, an economic term that can then be applied to everything in economics, which implies also health economics. So if there is an hospital that produces, stores, and sells something, there should be a unit cost for that. Now, you will see that the difficulty of measuring these unit costs will depend a little bit on how directly you can identify them. We were, for instance, using the example of the knee surgery, and there are things that are going to be quite intuitive, quite direct. So imagine that you need a certain amount of medicines to give to the person because of the knee injury. For instance, imagine that you need a certain amount of anesthesia to give the patient. You know that, and you can account for that. You need a certain number of doctors and nurses. Again, they are more or less direct. You can see how many you need, and you can try to account for that. But are they so direct? Because, for instance, I'm wondering, if you are in an hospital, you have a certain number of nurses, and they will be there for a certain time, so they work the entire day. So it's not like you can put the entire salary of a nurse to a specific procedure in a given day. You need to understand from the entire salary of the nurse what percentage should be allocated to that procedure. So one way, and Valerio already hinted at that, one way to do it is that imagine that you know that a nurse is going to spend 2 hours on a procedure. So you can try to understand how much should be the hourly rate for the nurse. So if it is 2 hours, you compute 2 hours times the hourly rate. Now, there are other things that can also be quite complicated. For example, I think no one gave this example, but if you are doing a surgery, you need a space. You need a room. If you need a room, you probably need electricity. You need water. And again, in an entire hospital, that room is going to be part of the rent or whatever the cost of running the entire hospital. The electricity is also in the middle of the total electricity cost that you pay. The water, again, you have the total water cost, but you may want to try to determine, okay, how much should I allocate from the total water cost, electricity cost, etc., to this given procedure. So it's not necessarily easy. You need to make some assumptions, and you need to try to understand how much that single procedure should count in terms of your other costs, your indirect costs. But you need to do it, and then there are people who have done it. So fortunately, you won't have to compute those. And here I'm going to present you with 3 examples where you can find unit costs. So when you want to see a unit cost for a knee surgery, someone already computed it by checking the cost for the doctor, the nurses, the bed, the room, the electricity, the drugs, etc. And everything is going to be already there. So first you have this NHS reference cost, which quite honestly, it has a little bit of a little bit of everything. So you will find their emergency care, you will find ambulance, you will find critical care, you will find outpatient procedures, everything really. So everything that is done in the NHS kind of will be there. Sorry, I left. Oh, what am I doing? Sorry, clicked the wrong button, and now, oh, sorry. Can you see it?
Yeah.
So then you have, for instance, this second one, unit costs of health and social care, which I have used, and I'm going to give you an example right in the next slide about social care. For instance, the cost of an adult social care or a carer for adult social care. I think that is more correct in terms of English. Then you have, for instance, the British National Formulary, which is going to give you the values for I think most types of the drugs that are used, so you can find what are their prices. So you can also, if you are accounting for that cost, you can also have those numbers in an economic evaluation. So now I told you that I was going to give you an example for the health and social care. So this is something that I did. So I really had to search for this. I went to that link, so you can go back and you can click it. I went to that link. I went to the report, and I wanted to know the costs of this. So the unit estimations for a social worker for adult social care, and you can see how things are going to show. You can see how the unit costs were computed. So first, in the first column, you can see the costs and the unit estimation. In the second column, you can see the values. And of course, you need to have a year for those values, because there are inflation and these numbers will change from year to year, most likely. And then finally, you have the notes explaining more or less what the first columns are, what you are seeing in the first two columns. So the first thing you see, it's quite obvious, is a salary. We should account for that. That's the first one we would remember. And you have the price per year, the cost per year of that salary. Then you have salary on costs. If you don't know what they are, you can come here to the notes. It's basically going to be the contributions like national insurance. Then, for instance, initial qualifications, and you have a price again. If you don't know what that is, this is going to explain that it has to do with initial qualifications that you need to provide to the social care for them to be eligible and capable of doing their work. Then ongoing training, in this case, there is no value, but imagine that at some point you need to provide some more training to these professionals, then it could be accounted in here. Then you have overheads that are divided into direct overheads and indirect overheads. Again, you have the values. So you can see in the notes what they are. Direct overheads include costs to the provider for administration management, as well as for office training and utilities such as water, gas, and electricity. So more or less what we already had into account in our examples. And then you may have also the indirect overheads, which include general management and support service such as finance and human resource departments. Then you may have capital overheads, which are related with land requirements, etc. You may have travel, which here there's nothing, it's blank, so they don't account for this cost, but you could have. And then this makes the costs for a social worker for adult social care services. If you put everything together, you have the yearly costs. Now, you can see here in the next slide, the total costs, the sum of all of those. Now, the unit costs this is important to know. There is no unit, no standard unit. The unit is the one that you will need to use. So you may want the unit costs per year, you may want per hour, or you may want per week. So in this case, you have the working time for any of these possible situations. So if you want per days, you have the number of days in here that the social worker is going to work. So you just divide the total costs by the number of days, years, sorry, by the number of years, no, days, sorry, the number of days per year, so by the number of days, and you will get the unit cost per day. If you want per hour, you have here the total of hours, you divide the total cost by the number of hours, and you have the cost per hour. If you want per year, it's the same thing. You just per week, sorry, I'm looking at per year for some reason. I apologize for that. So if you want per weeks, you divide these total costs by the number of weeks, and you have it. So it's, I would say the most common way to show it is per hour. So here you have it, the unit costs per hour, and they make a distinction, so with qualifications or without qualifications, which I assume is this part C in here. If you count the qualifications, it's 53 pounds per hour. If you don't, it's 44 pounds per hour. So, and that's it. And of course, if you need to compute it for any of the others, you just need to multiply by whatever you need to transform it in weeks or in days. Now, just to show you how these things are going to appear potentially in the economic evaluation that you are looking at. So this is our example of our original, the first RaCEEs, the Chowdhury et al. And we did this one with the Raj et al. This is ours. And you can see what we wrote. We wrote that the model considered both medical and non-medical costs, including hospitalizations, emergency room visits, consultations, professional caregiving, and respite care. Healthcare costs were estimated using regression analysis. Professional care accounted for a significant proportion of the total costs, with the cost of nursing home staff being the most significant factor. So we only wrote this, so it's very minor, but finding this in the entire text may be slightly more complicated. You will see that there was more text that we tried to condense in that small part. So going into the original paper that we are commenting, you can see that things should appear in a section like this, something like resource use and costing in this case. And you can see even that you have two subsections. So the first one, medication costs and associated administrative costs, and the second section called costs associated with health states. So yes, we had to check all the costs. And in this first part here, it is basically the cost of the drug, kind of precisely the thing that we were looking at, which is this LCIG, which is the type of treatment that people would receive for Parkinson's disease in this case. And this first paragraph is mostly about that. Then the second paragraph is mostly sorry, about other materials that would need to be used in order to implement this treatment. Then if you go here to the costs associated with health states, this first paragraph was mostly about precisely those health states. And just to make it simple, people with Parkinson's disease could have different types of severity. And if they have higher severity, the costs would be bigger. If they have small, not as high severity, the costs would be smaller. And it's basically explaining how they did to try to understand what the costs would be depending on the severity. And then finally, this last part in here, it's about the professional care, the professional staff types of costs. Now, the last slide from me is just to tell you that there there should be some tables. Most of the times costs will be represented in some tables. So I'm going to show you the table precisely from this paper, from the Chaudhary et al., where you can see the things that we talked about today in a table, basically. So again, we have this treatment, which is this LCIG treatment for Parkinson's disease, which is kind of it's not exactly a drug, but let's treat it as a drug. Doesn't matter. For now, let's treat it as a drug. And you can see that you have resource use in the first column, and you have cost, exactly how we talked about. Now, you can see that you have initially they account as resource use the LCIG cassette daily, the one that they need to use, and then you have as a cost the price of that cassette. Okay. Just if you are wondering, the SOC is the standard of care, the one they are comparing to, but let's look only at the LCIG for now. For this example. So other medications, again, they have the resource use. So these concomitant oral medications, including COMT inhibitors. And again, you have the price annually for that those medications. So you can see here in the LCIG startup, you have this NG tube insertion and this PEG tube insertion, which they need one of each. Then you also have this titration and monitoring for 5 days, which again, they need one of these. And then you have the price for each of them. I just realized that before I was pointing here, but this was the standard of care. This was the real price. So sorry about that. Now, then you have the other factors. So there's no point in going through all of them, but you can see that you have always the resource use in units, and then you have the cost of the implementation of the intervention. So this is the continuation of the table if you want to look at it with more attention, but it's still the same. You have adverse events, because they account for adverse events, replace, reposition of tube in surgery. You have one. And here you have the cost. So if you have the time, look at this paper, look at our comment on this paper to get an idea of what we need to do by the end of this workshop, or by the end of this course in the workshop. But yeah, any questions? Yes, Lucy.
Can I just thinking about the knee operation and NHS reference costs, do they tend to cost sort of best case scenario, sort of a non-complicated procedure? Because I'm just thinking, as soon as, say, an operation becomes complicated, time and cost will go up. And I think it's just making me think that's something I've heard talked about within the NHS. And then even thinking about the social care example, it's sort of best case scenario that somebody's working, there's no sick leave. So do economic evaluation sort of take account of almost real world scenarios?
Shall I go, Luis?
Yes, if you want.
Yes. The answer is we try to capture all the complications. Yeah. So we had a study, for example, where if you remember the decision tree that Luis was presenting in session 2, you got probably a branch no complication, a branch with complications. So if you know the probability of having complication, then you will be able to then try to cost those complications. Yeah. If you have some data, usually I will say, yeah, you can find some data. So you got the cost of treating the complication, what kind of medication you need to use, and so on. Yeah, but it's all linked to the probability of having that or not. Yeah.
Thank you.
Any other question? If you have any questions, just unmute yourself and ask.
Yeah. How do you cost in virtual consultations? So, obviously during the pandemic, a lot of face-to-face clinics were transferred to, like, a form of telemedicine. So there was video consultations and things, and a lot of trusts have continued to use those. So obviously you'd still have to have the time of the person who's conducting the consultation. That wouldn't change, but because you haven't got a patient there, I mean, for instance, for our population that I see in clinics, you'd have a nurse who would maybe weigh and measure the child and everything, and telephone or video consultations would still be allocated the same amount of time, but you could potentially be a bit more kind of productive. They might be more efficient, I don't know. But how would you cost them in terms of the saving for patients not having to take time off work, pay for parking, travel, but also, I think more importantly, there may be potential reductions in do not attend, because you're relieving them of all that inconvenience. They're more likely to actually attend. So I know, is there any way of costing up for virtual clinic?
Yes, you just use exactly the same principles that as we explained today. So you are going to cost the amount of time that the doctor is going to spend on the consultation. Now, if the doctor needs to be in a room in an hospital, imagine that the hospital needs to imagine that the doctor needs to stay in the same room, you are going to count the cost for that. If the doctor needs a computer, needs some types of technology in order to be able to examine the person without being with the person, you need to account for that. Then, in my experience as a researcher from reading, I think teleconsultations tend to be more expensive in general, because I think you tend to account for everything else that the doctor would already need to do, plus the new technologies and so on. So they tend to be more expensive. And in fact, as you mentioned, I think the selling point on those is that the patient is not going to need to miss work, because the patient is not going to have to go to the hospital and so on. So from a societal perspective, that is highly advised, looking at teleconsultations, that could be that should be measured, and that could be a selling point, that because the patient doesn't have to go to the hospital. In fact, it may be cheaper. But I'm not sure if Valerio agrees with me. So I would like.
I agree on the point of the patient, and I think when we talk about avoided costs and savings, it's always we need to be careful about not double counting things. So if you got a comparison between video consultation versus, let's say, traditional consultation, it's a case of costing how much the traditional consultation costs are, basically. So the patients having to go there, the time, the fuel, and everything. And that would be the cost for the traditional consultation. And then the video consultation will have its own cost, but we shouldn't consider savings and the costs at the same time. You either consider the costs or you either consider the savings. Now, what guidance tells us is to consider the costs of traditional consultation, cost them up, and then cost the things for video consultation, and then try to do a comparison. Otherwise you do double counting. So yeah, that's what I will say. But is key. We had remember, we did a systematic review on digital health intervention not so long ago, and we try to capture all these things and try to see whether there are ways which goes beyond the normal way of doing economic evaluations, which we can apply in economic evaluation of digital healthcare interventions. Yeah. Just conscious of time, so I will move to the last few slides.
Just a note that here you can see the NHS national schedule and reference costs, which we just referred in the slides before. So yes, they are indeed very important and used a lot of the times. So yes, go Valerio.
Okay, thank you, Luis. You can just maneuver the slides.
Yeah, I will.
Okay, so just want to cover these slides because I think it's very important. Sometimes you find studies which are set in different countries, and we will start wondering, okay, what currency am I using there? Because it might be, patients in the US, patients in the UK, patients in Australia. So you'll often find that the authors have to decide on a common currency. Of course, when you choose a common currency, there's not really a strict rule that people have to follow. It might be, I don't know, US dollars, UK pounds, or so on. It's just an arbitrary choice. So, but it's good. It will be good for authors to decide on a common currency in order to have all the costs in a specific, unique currency. And the same for the price here. If you think about a study which might last for 1, 2, 3 years, and then you might do the analysis after another year. So, the time it takes to actually produce the result, it might be a long time. And Luís was providing some example about unit cost in 2022, 2023. Now, if you did use those costs now, we will need to convert them into potentially 2025 prices, because we need to take account of inflation, for example. So it's good. It would be good for authors to also indicate a common price here. And this is an example of a good statement, let's say, that you can find in Economic Valuation, where the authors have said the all costs were converted in US dollars and the price here was 2020. That's all you need. And if you want to know how things are converted, this is you got a link here to a cost converter, which we use all the time. And you can have a look at how costs will increase with time. Next slide. Oh, thank you, Lisa. So just talk about next homework. You'll have one task similar to the task from the last session. You will have to fill in a table with info on the cost data this time. And you will find the document on Teams, clicking on session 3 costs. And then if you open that folder, you will see a document with your name, the same thing as last time. And then you can see this table. So you open the document, you will see this table. First column is the type of a cost data you will need to consider. The second column is the question. So what we are asking you to extract with some information about this type of cost data. And then the last column is just for you to copy and paste the relevant bit from the paper. So again, it's an extraction homework. And if you struggle, please feel free to contact your team lead. And all the cost data should be in the method section, but some of them might be also in the results tables like Luís was showing before. And this is it for today's session. So if you got any questions about today's session or homework from last time, we are happy to stay for another 5 minutes or so. Otherwise, we will see you in a couple of weeks' time, Monday, the 16th of December, where we are going to cover outcomes together. So I just want to thank you for attending today, for all the questions and all the points you've made. It's really good to see so much interactions, and we really appreciate that. And we'll see you in a couple of weeks' time. Thank you very much.